all of you are already doing that. All of you are already doing that. So, I mean, have done that. I know you've been present for that. And the main thing is, if you can't be a real close participant, you can't participate in it, be an observer then. Some nurses want you to do it. They want you to be active in an admit or a discharge or a transfer, but some want to do it themselves. And I don't think, a lot of times, I don't think it's because they're just trying to be, overbearing, but they have so much to do and they want to get it done quickly. So in that case, you want to just step in, take your notes, see what goes on, because if you're going to work in acute care, believe me, you're going to discharge and admit all day long. That is the beauty of working the night shift for, the first couple of years while you're getting your sea leg on acute care. You don't do a lot of discharges, which take time, which they take time because you've seen that. But as far as transfers and admits, it's usually just an ER admit, but not, it doesn't happen as often, I will say, on the night shift. So that's one good thing about working night shift and not getting any sleep. Does anybody have questions about the discharges or the admits, transfers? It's pretty simple. I'm just going to say we had our discussion, and if you do have any questions, you can ask now, or you can ask your primary nurses while you're doing it. Again, if you can't actually do any of the teaching, be a participant. Don't take off and say, oh, my nurse is doing a discharge or an admit, I don't have to be there. They're not my patients yet. If it's your nurse and they get an admit or a discharge, please be in on it. That's just one thing I wanted to talk to you about. So I can sign that off for today on that skills sheet. If you have, there's 6 of you that after this lecture, I want you to stay in the meeting so we can talk about scheduling the last lab for the 6 of you that are remaining. Stay in after everybody checks out, because some people can do it. Some people are in clinical and it's not working out. And I'll be there both Tuesday and Wednesday, but some people have clinical both of those days. I'm not sure if you have clinical on Friday, but if this Friday is not going to work because I'm in clinical. So we're going to figure it out within the next 2 weeks to get everybody done. So we'll talk about that. And then there was one other thing. I didn't write it down. I'll think of it. As far as your renal papers, which are going to be due before your renal quiz, and then this oncology paper that's going to be due, it does either 6 or 7 for the APA book is fine. It doesn't matter, whichever one you want to use is okay with me, but you have to keep it under 2,000 words, because some people went really over, and they're beautiful papers that I've seen so far, but they're just too much for this assignment. So just look at your rubric and see what it says. It says, don't exceed 2,000 words. And one question was, does that include your reference page and your front sheet? It doesn't. Those are just the words in the body of the paper. So I know a lot of people didn't even look at that over the break, and I hope you guys had a good break because it seemed pretty short. But now, you guys, there's 2 more lectures and we're done. Med-Surg 3 is done, peds is done, and the rest is all the stuff that you guys have to do. Josh is having a seizure. I think he's so happy. The rest is preparing for your ATI and your finals. So that's something that, oh, he's blushing again. Yay, Josh. My 10th boy that blushes. I love that. But yeah, no, it goes by quick and we're almost done. So far, everybody's doing good. If you're not doing well, we are going to meet today. And that was what I was going to say. This site was so hard to get on and off of for everybody. Just pause it, go away for half an hour. After we're done with this lecture, we'll have a half-hour break, and then we'll just come right back onto this site to finish up our peds lecture, because going in and coming out, I don't want to have a bunch of problems again. It looks like everybody's here now. So, and if they're not, they're bummed. What else I can do about that? So just stay in this one. The oncology section is not that in depth. We're not that, we just barely touched the surface. That's why we figured that, and same thing with renal, it's good to do your paper on these on these two sections because they are actually patients that you guys have taken care of. You guys have taken care of patients that have had cancer or that are in treatment for cancer, and maybe not just on one Compton. There's a slide that said, or in your skills sheet, it says 6 Central, like you're going to do your calculations, and 6 Central was the name of the floor before the new hospital. So 6 Central no longer exists, and that isn't, so we're just doing one Compton. So we'll have to change that on all the CPETs, but we can't just change it. We have to change it one by one. So it's going to take a while. So I think today, after class, when I put in your actual, the last skills that we have, I'm going to just change it to one Compton. So that's where we are with that. So if you see 6 Central, it's not anything that you have to worry about. The required reading, again, is not that much. Reviewing the different types of cancers and like the stages A, B, C, and D, E. It's like genetically altered epithelial cells. We talk about it, and a lot of people have either had a type of cancer, have had family members that have had different types of cancers, lost people, have people that are in remission from cancers. So it's kind of like something that usually always hits home. And I've had many, many, many students that say that they came into this field after taking care of a family member or friend that has had this disease. And there's so much new technology, and I have to say that Santa Barbara has really come up with the Ridley Tree Center, and they've done so much research, and they've got a lot. I mean, people still get sent away. People still get sent to LA for different types of cancers, and there's Loma Linda, or there's Cedars, or they go to UCLA for different types of treatment that maybe aren't here in Santa Barbara, but we do pretty well. Santa Barbara does pretty well in keeping their people close. Taking care of the patients on one Compton can be super heartbreaking, because even if you've only been there for part of the semester, you definitely get attached to them. I feel like I've had so many people in my life that have had these conditions. And when I read the papers that you guys do, a lot of them touch on several different things. There'll be people that will have the non-Hodgkin's lymphoma, or just like a malignant melanoma from a skin cancer, prostate cancer. There's just so many. And again, like if you have had a patient and you have information on them, go ahead and write on them. If you have not, choose one. But the point is, if it's going to help you with this section, learn something a little more in depth, then it's worth you doing a 2,000 word essay on that. Reviewing, so we'll go over genetically altered epithelial cells, hyperplasia, that cells divide more rapidly than normal, dysplasia, cells change in form, in situ cancer, cells that stay in one place, and then a malignant tumor. Cancer cells invade normal tissue and enter the blood and lymph. Then they metastases form at different sites. And that's usually like the more aggressive one that's metastasized in other places. Naming of the cancer. So it just goes like the prefix and the meaning of the area. So the gland or the cartilage, the blood red cells, blood vessels, liver fat, lymphocytes, pigment cells, bone marrow, muscle, and bone. And these prefixes give you an idea of where that cancer is. Adeno would be the gland, chondro, the cartilage, erythro would be in the blood, hemangio in the vessels, hepato, liver, lipo in the fat, lympho in the lymphocytes, melano in the pigment cell, myelo, bone marrow, myo, muscle, and osteo for the bones. And the classifications would be proliferation and differentiation. So if you look over here to the right, you'll see like the target cells, the altered cells, cancer cells, proliferation, where they start to, split, divide, and advance. And then the evidence of clinical disease, evidence of regional spread, and the metastases. So in talking about the different types and the proliferation, we'll go through, you know, I feel like these pictures are good, but they don't really hit home because a lot of people can't relate to this, like proto-oncogenes and tumor suppressor genes. But it does show you like the little picture of how they proliferate. So tumor suppressor gene proteins, and then over here you have cancer-causing agents. And any more in our society and in our culture, everything has cancer-causing agents in it. I mean, you can't step outside without inhaling pesticides, or, you know, the way food is made and processed, and you see like so many things that research is saying is causing these different cancer causing agents. And I just feel like, you know, what do? We live in this world. It's so scary. It's everywhere. And they say, oh, stay away from processed foods, or stay away from, you know, like even cosmetics, different cosmetics, hair dyes, you know, nail polish, just anything has got all these cancer causing agents. So we are surrounded by all of it. And what do? We still have to live here. I mean, classifications: benign neoplasm and malignant neoplasms. You see, benign would be adipose tissue. If you have a lipoma, you can go and get that excised. You can get it removed. Malignant liposarcoma would have to be a further treatment. And there's a dial that I show you that talks about the different types of treatments. So if you look at the classifications, you can see, you know, for the benign, for a benign tumor, so to speak, for all these tumors, you hear a fibroma, you can go in and you can get that removed, that kind of thing. But again, if it's malignant, there's going to be treatment. The stages will be initiation, promotion, and progression. And in this picture, just see if I can fix it up, move it up a little bit, sorry. Initiation, you have the promotion, progression, and the metastasis. So, I mean, if you go through a DNA repair, there's blocking agents. You go over a little bit more on this little algorithm, you see suppressing agents. And the goal of the Cancer Foundation Society and our community is to stop the progression, correct? I mean, that is pretty much what our goal is, and give people back, you know, a homeostatic place in this life. But a lot of times it doesn't work that way. And you see the patients that have gone through so much, they get in remission, they have maybe a year or two, and then all of a sudden it comes back. And I feel like those cells are still there just waiting. I mean, you have the different classifications, and they're classified these tumors, and you see, you know, tumor cannot be evaluated due to lack of information. So there's a tumor, but they're not sure. A lot of times they get excised, and you go through like anatomic classification, histologic, and staging. And I like to talk more about the staging, but breast cancer, it seems like, I don't want to say everybody has, you know, experienced the breast cancer situation, but so many people have. So many people have experienced it, not only with a family member or a friend or a patient, but you have the different stages. So here at stage 0, the tumor, very small inside the gland. There's no cancer, confined to the breast area, not outside, and that's 100% survival rate. But here you go over to the stage 4, and it could be any size affected by cancer. Cancer has spread outside the breast area. And you talk in talking about breast cancer and the stages, there's the you know, where a woman or a man checks themselves monthly, and it's these checks are like, some people say, oh yeah, gosh, I haven't done that in so long. Or they'll say, on the 1st of the month, you know, when you shower, do your breast exam, check to see if there's any, you know, change or anything different. And in that case, then it needs to be addressed. But if it's done every month, same thing with like scrotal exams, and people are all get, you know, kind of weird with talking about that. But if you do it once a month and you check for any abnormalities, it could be, the difference between living and dying. And as far as like catching something early on, especially with tumors, it's something that you can teach your patients, you can teach your friends, family members, everybody. Don't forget to do your exams. Make sure that you're, looking at these things because they are out there. The scary thing about this, and this I put up because changes in bowel and bladder habits, a sore that does not heal, that's, generally usually a skin cancer, unusual bleeding or discharge, thickening or lump in the breast or elsewhere. A lot of these things can be interchanged with something that isn't that serious. Like, for instance, let's just say change in bowel or bladder habits. Let's say it says it's a common sign of colorectal cancer. Some people get, I don't know, bowel or bladder habits when they get nervous or when they get very high stressed or when they change their diet and they start eating something different. A sore that doesn't heal could be like a skin infection that is not necessarily a skin cancer. If it doesn't heal after a long period of time, then it needs to be addressed. I mean, I just lost a patient that lost her eye in the process, and it was like over a period of 4 years, but it was a tiny little, on the bottom lid, a little tiny sore that didn't heal. And she was already in her late 80s, and her family said, it's fine, it's not a big deal, we're not going to take her in. She's not going to want to do anything about it. And I was like, well, it's just a really tiny spot, but it hasn't healed in a few months and it really needs to get looked at. It could be something very minor. Well, it didn't get looked at. It didn't get looked at until the sore was so bad, the lid started drooping, the bottom lid. And then when they finally did take her in, they told her, you'd have to have a week in the hospital. We'd have to do a whole facial reconstruction. You're going to have to, you may lose your eye in the process. All of these things that kind of discouraged her from doing anything. And that was like 2.5 years ago. And then, 6 months later, she can't open her eye. And then a year later, there was nothing they could do. The whole partial orbit was sunken in. And then she just passed away from it. But I feel like when it's something like that, where you see a sore that doesn't heal, it doesn't take but any time to go get it checked. And some people will say, well, I didn't have insurance. I didn't want the expense, but the other expense, I mean, going into an urgent care, going into the ER and saying, I really need to get this checked. Can I get, emergency coverage? Can I get something? Because those kind of things, they don't go away. They generally don't go away. Unusual bleeding or discharge. It says here, any bleeding from the bladder. It could be a kidney stone, not necessarily a tumor. Or vaginal bleeding. It could be, we talked about that. It could be, a change in your menses because of a lifestyle change or something, too much bleeding. There could be fibroids. It could be not anything that has to do with cancer, but it's definitely something that needs to be addressed. Rectal could be a hemorrhoid that's bleeding when someone strains. But all of these things bear looking into because they're just something that you don't want to wait until you're at a higher stage, like a stage 3 or stage 4, when you could have addressed it. And like they're saying every 10 years you get a colonoscopy after the age of 40. So things change, every while. It used to be after the age of 50 and now it's 40, you need to get colonoscopy done. And oftentimes there's little polyps and they're not anything that, they remove the polyp during the colonoscopy. People get a little bit sore, but having colon cancer that has spread is something where people lose their whole colon, their rectum. They have to have, colostomies and that kind of thing, or just, a colon resection and then advanced treatment of chemotherapy and radiation just to hopefully get rid of all of it. So there's a lot of different things. So that would be, bowel and bladder. Thickening or lump in the breast, again, like we just talked about, encourage people to do it. And if you aren't doing it, do it once a month. And it's something that it takes, you have to take a shower every day. So it's something that you can be checking, female and male. I did know a man that did have breast cancer, and he actually did die from it because it was such in an advanced stage, because he was a very heavy set man and he never did any kind of breast exams. So when he did find that big lump, he thought it was just, his weight. He was pretty overweight, and it was too late the treatment didn't do anything for him, and he did pass away from it. So it's not, it's obviously more prevalent in females, but males do get breast cancer. And again, if there's lumps in the testicles that are not just normal tissue, those also need to be addressed. Symptoms in the stomach, throat, esophagus, and mouth cancer. Any little sore in the mouth, any stomach pain or upset that's not going away. You're treating the symptoms, or you have a sore throat, you have, some like regurg. A lot of times it could be GERD. It could be just a reflux that's causing this esophagus to be sore. Mouth cancer is something like a sore in the mouth that doesn't heal. That's really, we lost one of our students to that. And it was so sad because he did use that tobacco that you put underneath your lip, your bottom lip, like in a little round can. And his classmates, he was brilliant. He was so smart, never took one single note in class and got A's in everything. He had a photographic memory to where he retained everything, and just a really lovely guy. And he got, a sore on his tongue that he didn't go get looked at. But when he was getting his teeth cleaned, that's why the dentists get that little 2x2 and check each side of your tongue. Oh, how long have you had this? I'm not sure. Well, you need to get it checked. And sure enough, it started with rehab, losing half of his tongue, and then it had metastasized in several places. So it was something that was really heartbreaking for the community, because he was just a really, really good guy. Warts or moles. The example that I always give is you do the 4 eyes on your patients, two nurses, an aide. You look at your patients, you check the skin, you check everything. And one of our students some years back had a 36-year-old that had fractured his femur. He was a surfer. He lived alone, 36-year-old, great guy. And when she turned the patient over to do her assessment, she saw a funny mole. And it was on orthopedics when we were in the old hospital. And she said to the patient, because here it says, a wart or a mole that, has changes. Well, number one, if you live by yourself and nobody's looking at your back and you're not looking at your back, how would you even see it? If you don't go get regular, dermatology checkups, which this guy's like, I don't go to the doctor. I just broke my femur. I'm just here because of that. He was a generally healthy young man. He was a surfer. And the student said, well, I just want to show somebody, because it just doesn't, the type of mole that it was, and it had different weird edges. It wasn't pronounced round or anything. So she called her primary nurse, and he said, well, the surgical residents are here. Let's ask them. The young brand new surgical resident comes in and he goes, I think we should biopsy that. We'll do a punch biopsy. And the guy's like, that's fine. I don't care. I'm probably getting out of here in a couple of days. Well, they did it. They sent it to cytology, and it was a melanoma. And it was a type of skin cancer that was so fast and so aggressive. And the guy said, I have no idea how long it's been there. I have no idea if it's changed in the last month. I feel perfectly healthy and fine. And they immediately, started with, an oncologist came that day. They talked to him that day of the result. I think it wasn't until the next day they got the results, or the next 2 days. And he was almost ready to go home. And they said, no, we need to give you your treatment options. So that was from a wart that a student found. Now, the guy went right, got a line put in, started chemo that week, went through 6 months of treatment, and came back after his treatment and radiation, came back to look for us to find the student that said he said she saved his life. And that was just like, it was a big deal back then. It would be a big deal anytime. But I feel like, I used to kind of argue the fact that Med-Surg 3 students shouldn't be giving bed baths. They should be focusing on their treatments and their meds and all that. And it got stopped for this reason. Because you're so new in practice, it's so important to do those bed baths, to be able to see the entire body, to be able to get familiar with people's, baseline. Like if she wouldn't have done that bath and seen the back of that back and done her assessment, she never would have seen that. And that guy never would have gotten treatment for it. It's very unlikely that he would have gotten treatment. Now, if that cancer, which was very aggressive, he did 6 months of treatment, he came back, he brought flowers, he wrote this huge letter, it went to the college. It was a big deal because this student had enough sense to dig deeper. He never would have made it. He wouldn't have, because it would have gone into such an advanced stage. By the time he started feeling very sick and able to go get, looked at, it would have been too late. So that was, a mole that was looking kind of strange, not, in a circle or conformed. It was kind of spread out and weird. This other one, a nagging cough or hoarseness. Now, if anybody has terrible allergies in this area, you would know that oftentimes during allergy season, you get that postnasal drip where you would have that little, you'd have a cough all the time, or hoarseness can also come, and that cough can also come from antihypertensive meds like a Vasotec. That pill causes a dry cough. Now, some people just have dry coughs, or they're smokers and they don't address that. They don't talk, it's just not a big deal for them. But it also could be, it says a cough that lasts for 4 weeks or longer can be a symptom of lung or throat cancer. That's kind of one that gets brushed under the carpet all the time, because people do have that. If they have allergies, if they are smokers, or if they take a medication that would cause that. Treatments are different for every person. And oftentimes when people get the cancer diagnosis, they think in their minds, like, either I'm not doing anything, I'm going to live my life and, forget all that. I'm not going to go through any of that. I'm not going to weaken myself and then just die anyway. And then there's people that are super aggressive and say, I want to try everything. I researched it, and in, the Midwest, there's a physician, a hospital, or in Texas at Anderson's, they're doing a clinical trial. And if I go there and commit to it, I won't have to pay for it. So in other words, being an example or a guinea pig for one of these trials, some people are very desperate to live, and others aren't. So it just depends on who the person is and what kind of options they have. And it doesn't mean that, oh, well, that person died because they didn't care. I mean, some people try everything and it doesn't work. So if you look, I like this dial because it kind of goes to the initial treatment phase. It goes chemo, surgery, or diagnostic phase, chemo, surgery, immunotherapy, then radiation therapy. And if you go in a circle and you look at the dial where it says to the cure. So if you've gone through all these things and you do a follow-up phase, no return of the cancer, what is it? NED, no evidence of disease, and you have your usual lifespan, obviously that is ideal, right? I mean, that's what best case scenario. Does that happen for everybody? No. And if you go through your diagnostic phase, let's say you have surgery, you go through chemo, you do the IVIG therapy, radiation, you go through the control phase. It says phase follow-up, retreatment. So you might have to do this all over again. And you have a supportive phase where things look like they are remissing, you're in remission, usual or reduced lifespan. So maybe you'll have just your regular lifespan, or it is reduced, it's very hard to dial that in and figure out exactly where you are in that area, because you don't know, it's either going to be usual or it may be cut back a little bit. So if you think of that, you're thinking like that's kind of a gamble. And then you go down to initial treatment, you've done all those things, and there is no response to the initial treatment. You've done the surgery, you've done chemo, radiation, you're doing the IVIG, the immuno and targeted therapy, and the disease is advancing. You're in the advanced phase. So oftentimes we do get patients like that we're taking care of. And it's kind of a slippery slope, because somebody that is in an advanced disease phase may have something else that needs to get treated. Like, I mean, a gallbladder problem or something. They don't want to just stop there. So it's hard to say, if you're doing palliative care, what kind of treatment you can have when you're in the hospital. And you go to a supportive phase where it's just palliation and they're not doing any kind of treatment, meaning you're only getting like supportive care, meaning you're getting like maybe just pain medications and fluids. And of course, you're going to have a reduced lifespan. And once those things are not even working, when you go into hospice care, that's also very different. You know, hospice does not encourage like patients, if they go to like perhaps a Serenity house, you're not getting fluids and you're not getting fed, you're getting pain control. And pain control meaning like you're either on a drip or you're getting like Roxanol, where it's an oral narcotic that is just alleviating the pain. And not only the oral narcotics, because at the end of life, there's a lot of secretions and your body doesn't know how to manage the secretions. So in that case, if the secretions are overtaking things and causing the patient discomfort, they'll use an anticholinergic. And the cholinergic would be, it's crazy, but there are eye drops that are anticholinergics, and the eye drops are dropped underneath the tongue to kind of slow down secretions. It's a strange thing. And the first time, it was years ago, I was like, this is an eye drop, try it. And definitely my patient secretions lessened, because it's the gurgling at the end of life and the fluids that the patient is unable to manage that can be not just so painful for the patient, but it's very painful for the family or the surrounding caregivers, the people that care for this patient, family or friends, whoever's caring for them. Listening to that and thinking that they're drowning is very difficult. And it could be that the patient is actually no longer able to feel any of that, but you're still suctioning them and hoping that they're getting, you know, a little bit of relief. This is just something that is part of a treatment plan, and super hard to watch. And I've seen it many times, and I was just present when the hospice community came, and there was 2 physicians, psychologist, a nurse that actually gave the medicine, and she died. And I've never seen anything like that. I've only seen it once. I've certainly been end of life care where hospice gives you the meds slowly and they go through the whole process. But this woman went through, I think, 6 months of signing consents and saying, when I get to this point, I do not want to live anymore. I want to be given these medications that will assist me in my death. And to me, I'm still not over it. I don't understand it, is what I should say, because I don't feel like that's part of the oath that we take as a nurse. And she was a nurse and she was lovely. And she did everything with so much respect and kindness for the husband. And the husband was so devastated. It was just a whole different process. And that was end of life care. As far as oncology treatment, I feel like when people give it their all and still, you know, it comes to that kind of thing where nothing's going to work. It's so unfortunate and it's hard to understand. So like for all of us as, you know, student nurses, as nurses working on a unit like this, at working on any unit when you have a patient that's undergoing chemo and radiation and this sort of thing, you'll see the different side effects. You'll see what they're going through. We'll talk about that in just a minute, but the drugs to eliminate or reduce the number of malignant cells. Now, with that being said, I have a very hard time understanding that a chemo drug goes into a very sick patient, right? I mean, they're very vulnerable, they're very sick, and it is going to splice the cells, and try to kill the cells, split the cells so that they don't proliferate. It's a very toxic, strong medication that's going into a very sick patient that we have to wear our chemo garb, right? Our PPE. You have to wear a face shield. You have to wear special gloves. You have to wear a gown that is just specifically for chemo patients. If any of that chemo drug drips on, like, let's say your dance clothes, which are leather or like fiberglass or plastic, it can burn a hole right through them, right? It can burn a hole in your clothing, but yet we're infusing it into a mucous membrane, into a artery and vein that is soft tissue. It's so hard to wrap your head around that and understand how these drugs work, how this puts these patients in remission. And it is really a quite complicated area of nursing. I know that students that have gone to One Compton, they love it there. They love the patient population, they love the nurses, they love the plans of care. They get to see patients go home, maybe come back for further treatment, but go home, and that they're remissing. It's just something that, in talking to many of those nurses that work there were my students, and I talk to them about it all the time. And as an infusion nurse, I have been taking care of them post chemo, post radiation, and they're still with us. So they'll come in like for an IVIG, the immunoglobulin therapy. And it is amazing to me that they survived that. Oh, look, I have a whole different head of hair. I used to have light hair, and now I have dark hair with curls. I have no idea where it came from. It must have come from another family member. It was hiding in my DNA. Just different weird things that you talk to these patients about that have been through this. So there's just a lot to it. It's here, chemo treatments. It says the patients lose their hair. Definitely forgetfulness, and they call it chemo brain or foggy chemo brain. They get, like, they can't remember things. They can't hold a thought or complete a sentence for a while. Some never get it back. Some get it back and say, when I was going through the treatment, I did get that chemo brain. Hot flashes are an early menopause for females. It's that feeling, which none of you, I hope, have ever had to go through, but that really just sitting, doing nothing, then all of a sudden your whole body is on fire for like a moment in time, and then it goes away. Contraception and fertility, oftentimes people become infertile. So it's one of those type of situations where, they're, after having a certain type of cancer, they are unable to have children. Itchy skin and other skin problems, meaning that it's really hard to keep skin moisturized, to keep like little tiny sores or cracking of the skin, because these chemo drugs are so extremely toxic. So there's certain meds. When I've given some of my clients, I gave one an oral med for about 2 years. Each bag of medicine that came after insurance was like $1,500 a month, and it came with a tube, and it was I wish I remember the name of the cream, and we'd have to put that all over her after every shower just to keep her skin moisturized enough to withhold this medication treatment. Numbness and tingling and hearing changes. The numbness and tingling are usually in the fingers and the toes, the extremities, and hearing changes can happen. Some say that it does come back, or there's like a constant dull ring like a tinnitus. Fever and infection, when you're on chemo, you have to be so careful because you are extremely compromised, knocking out your fighting cells. So you have to be very careful. And, they do wear masks everywhere, and they do, stay out of large crowds, that kind of thing. If they get an infection, they oftentimes have to go into the hospital for anti-infective therapy or even an outpatient infusion. Fatigue, that's a huge one. You'll hear people that go through a chemo treatment and they'll say, I'll be okay today, but tomorrow and the next day I'm going to be feeling really sick and really tired. Nausea and vomiting, oftentimes there's so much pre-medication, like they'll wear a pump before chemo, which will start like the antiemetics, and they'll wear a scopolamine patch behind the ear, and they'll get this medication while they're getting the treatment and 3 days after, just to feign off any of that nausea or the vomiting that can be so disruptive. Digestive changes, it can become like severe diarrhea or severe constipation. It can go either way. And the diarrhea is something that is really, both are very uncomfortable and can be life-threatening because you can have an obstruction if you're constipated, but the diarrhea can become so painful and so raw, the rectal area becomes just blood raw from the constant diarrhea, and the mouth, same thing with the oral sores in the mouth and all that. They can't eat, they can become dehydrated very quickly. And you'll see sometimes that when the chemo does this to a patient, they will be inpatient, because then their line will permit them to be getting, constant rehydration and medication through the IV that will help with that. Sexual dysfunction, again, that can just like stop the drive for any kind of sexual activity. Changes in the bone marrow, it can also cause, a patient to have brittle bones, fractures of their bones, because there's changes in the marrow. They're not building the red blood cells. All of those things are complications. In the hematology, it could be the neutropenia, so the absolute neutrophil count, anemia, and then the thrombocytopenia. Treating these things, again, we talked about when we talked about anemia, we can treat these with transfusions, and oftentimes they come in for weekly transfusions or 3 times a week to get a transfusion, and then only to have another chemo treatment to knock those red blood cells right back down. Different anti-cancer drugs by classifications. You have that, alkylating agents and just different types that you can be, familiar with. You have the anti-tumorals, different types for your farm ATI. I put them in here. Anti-neoplasmics, and there's a few different names. Some, I want to say, usually when any of our patients are in the hospital and then they're in the hospital for a different reason and they're getting these orals, these aren't medications that many nurses, unless you work on oncology, are familiar with. So it's good to just take a look and see what, see what they're on, see what they're causing. I mean, a lot of them do cause bone marrow suppression, but again, they are counteracting and fighting off the cancer cells. So just medications. This one, the tamoxifen, is something that I'm sure many of you have heard of, and it's a selective estrogen receptor modulator. It says selective estrogen receptor modulators, such as tamoxifen or raloxifene, have both estrogenic and anti-estrogenic effects on various tissues. So it's used primarily for breast cancer in both men and women. And then the raloxifene produces estrogenic effects in the bone and lipids, and has an anti-estrogenic property in mammary tissue. It's used as a prophylactic against breast cancer and high-risk postmenopausal women with osteoporosis. So if you have been diagnosed with these type of cells or this type of history, some women do use this as a prophylaxis. Again, just general adverse reactions to anti-cancer drugs. And that's where also we talked about the Neupogen and the Epigen, oftentimes those are given to these patients to help build themselves back up, not just the renal patients. Different reactions, you'll see mucositis. I mean, these are when a patient has terrible, terrible diarrhea, alopecia, fatigue, infertility, all of these things. Usually the oncology treatment for radiation after a chemo has been given, or unless it's a type of cancer where they're not going to go with chemo, let's say they had a specific type of surgery that removed it, and they don't recommend any kind of oral or IV chemo, and they'll say, we're going to just radiate the spot where that cancer was and hope to eradicate it. You'll see patients that go in, they go into that machine and it's super weird. It's like this, mapping that they do. It's like very high tech, and they'll go directly to the spot where it was. They'll put like a little tiny dot tattoo where the radiation, where the treatment is going to target. And it's pretty interesting to see these little tiny dots. They do look like the little tattoos that old folks like us put on our hands back in the day, but they're, targeting that area, a little tiny dot. And they'll go in maybe 6 days a week. It takes not more than 10 minutes. They go in, they get radiated, and they leave. But here you'll see used to treat carefully defined area of the body. Stimulation is used to determine optimal treatment. It's external, and there's also internal implanted. And if you look over here, this was dry desquamation, and that is post radiation treatment. And this one is a wet one. And you can see kind of like this, definitely in the second picture, you can see where it is like kind of not a great outcome. I mean, they are having oh, give me that word. I don't have chemo brain. Let me think about the word that I'm looking for. But you want to limit your exposure to them. You stay 6 feet away from them. You definitely wear your chemo PPE. You wear a badge that measures the amount of radiation, and all linen is contaminated. So these different outcomes for these patients don't look so great. Oh, it's 5 after, so I'm going to give you 10. We'll come back, talk a little bit more, and sorry about that. We did start late though. So careful. Sorry, we have to be so careful when you do any kind of bathing, any kind of skincare. And remember where it says limit your exposure. When a patient is, getting radiation treatment, oftentimes they don't let students in, but as a nurse, you would go in. But it just depends on the vulnerability of the patient. They could be a neutropenic, key component system defenses against an infection. You want to fight. They don't have any fight in them, so they can't get exposed to anything. And it's not, a lot of times we put in our garb, we put on our PPE because we have to protect ourselves. But these are generally patients that have to be protected against everything because their immune system gets completely wiped out, like after radiation or a blood or marrow transplant. We do the ANC, absolute neutrophil count. Is usually depressed, and that's something that we'll see in just a minute. So you'll have to know that. You'll have to know how to calculate that. But the neutrophils are key components in the system against infection. And when you don't have that, you don't have any fight left. You have to be super, super careful. Here are some of the, just straight from the book, the precautions. You clean your hands frequently. I hope you're already doing that. You try to avoid crowded places. I mean, we are just post-pandemic, and oh, excuse me, 1 second, you guys. And going through shower or bathe daily, use an unscented lotion because the skin could have even the tiniest little crack, and you could cause a big reaction. Cooked meats and eggs all the way through to kill any bacteria. Carefully wash raw fruits and vegetables. It says here, protect your skin from direct contact with pet bodily waste like urine and feces by wearing vinyl or household gloves, like if you're cleaning up a pet box or giving an animal a bath. use gloves for gardening because the dirt can have the soil can have definite, bacteria. Clean your teeth and gums with a soft brush, because if you scrape your gums, you set yourself up again for another infection or a sore. Use mouthwash to prevent sores. That sometimes can be slippery slope because the mouth is so raw that can really burn. Try to keep all your household surfaces clean. I mean, just get your flu shots. Now I would say you're going to be getting your COVID vaccines. It says if you're in the emergency room, you should not sit in a waiting room for a long period of time. So, especially tell them right away that you're getting your immunosuppressants so you can stay away from anybody that could be have an infection. Signs and symptoms of infection, all of these things like fever, chills, cough, sore throat, anything that would just be regular, like a little, not a big deal, could be a huge deal. So they have to be careful. This ANC is written out for you, and you can definitely have the formula when you take your oncology quiz, but there will definitely be one calculation on there. It says multiply the WBCs by percent of neutrophils. So it gives you like a little example. WBC 6,000, segs 30, bands 3, and it says neutrophils plus bands would be 33. So 33 times 6,000, and you get 1980. The ANC of 1980 by convention would be 1.9. Normal range is 1.5 to 8. So look at this, play with it a little bit. It gives you definite examples on how to do it, and it gives you the examples in the book. It's going to be a super simple one, but this is the calculation that you'll see maybe one on your test. It says in practical clinical terms, a normal ANC is 1.5 or higher. A safe ANC is 500 to 1500, and then a low is less than 500. So a safe ANC means that the patient doesn't need to be restricted on the basis of that ANC. But for neutropenic precautions, we still have food restrictions would be raw vegetables, deli meats, takeout foods, yogurt, that kind of stuff, raw nuts, roasted in their shells, unpasteurized milk or cheese, aged cheese like brie or blue cheese Roquefort, and then meat that isn't well done, like really cooked, like kill that meat, fruit that cannot be peeled, and then eggs that are not hard boiled. So, I mean, just trying to avoid any type of bacteria. Good hand washing, all of these things, no fresh flowers or plant. Like water that are in the pink pitchers, we don't do. We just bring in small bottles of water that they can drink, the small ones, the short ones. And they're on oncology for that reason, because they don't want a larger bottle that you only drink half and then let like the bacteria from your mouth sit there and brew. No rectal temps or rectal meds. And then for the diet, no raw meats, fresh fruits or vegetables, and you have to wear a mask. The GI involvement, mucositis, nausea, vomiting, anorexia, diarrhea, and constipation. Alopecia, so losing your hair or skin changes. And then there's neuro, cardiac, GU, and psychosocial. So just in talking about those type of problems for these patients, there's such a whole gamut of things that you really need to be aware of, and you need to be, thinking too. All of these physicalities can be going on, but inside, a patient could be suffering psychologically from this horrible diagnosis. Biologic altering response to the host, to the tumors, targeted specific cellular receptors. Then genetic, there's experimental that involves, genetic material into a person's cells to fight the cancer. The stem cell transplants, bone marrow transplants, all of these are other treatments. And in thinking of trying to get any of these done, I will say Santa Barbara, like I said, they are doing a lot more. There's a lot of different clinical trials going on, but oftentimes people have to travel out of the city and out of the state to get different clinical trials. Again, rituximab, different meds, just to be prototype drugs that you can be, you know, get familiar with the names. And again, like I said, even as a clinical clinician in the hospital, you'll see these meds and you'll go, oh, I've never even heard of this. These must be chemo drugs, you know, that kind of thing. So again, other treatments, I just put these up here just because, you know, sometimes we do have to try to think out of the box. Harvest stem cell or bone marrow for the patient, treat the stem cell or bone marrow agent, destroy all the malignant cells without harming normal cells, IV injection of the purified cells, and then the patient has to rebuild those back up, different chemos. There's all sorts of things. I know when my sister was going through treatment, she did everything because she had 3 small kids and she tried. She really fought hard and lasted like, I think, close to 2 years with the non-Hodgkin's lymphoma, but it was brutal and she really suffered with that stem cell transplant and all that. And, you know, she's still gone. So hard. It was hard on everybody. People want to fight for various reasons, or they don't want to fight for various reasons. So that's another thing that we have to definitely be, you know, sensitive to. These type of ports are ports that we don't access. Those are the only ones, yes. And every week somebody asks, can they give meds in the PICC line? Can they flush PICC lines? Yes, you can do all of that. But these ports we cannot, only the oncology nurses. This power lock right here, I accessed the other day on a gal that's got cystic fibrosis and she keeps a port in. She's got 3 young kids, super healthy, otherwise great gal. And we do it once a month. We go in and we heparinize it. So it is a weird feeling. It's something to watch if you can. I wish that if some of you are at Goleta Valley while I'm doing this, I will go to the unit and pull you over so you can see, you know, accessing this port. It's pretty interesting, just something to show you. And it is also, even though you're getting a patient and you're not accessing the site, you still have to assess it, you know, for any signs and symptoms of infection, redness, pain, anything like that. So that is part of your assessment. Let's see here. We've got something to look at, and I'm sure all of these are something I would really like you to watch because it'll help you if you haven't started your paper yet. And when we come back at 11, use this site. I'm just going to stop it and put your peds up. I will give you all the information that you'll need for the last quiz so we can get finished up with this class, and we'll talk about your clinical rotations and your paperwork in that. We go over that again because sometimes people forget, or, you know, it's just something that you don't think about because it takes so long to get there. But I will see you guys. And then after, and it's a very short lecture for peds, and we'll go over what's on the quiz. I'll keep the last 6 people in the site. And if I have to meet with anybody, I think I'm meeting with one person, we'll do that right after. Okay, this is, I guess, our very last lecture for peds, but before we do this, I think what I'm going to do is go over our clinical paperwork. Just take a quick peek at that. So it says you have completed 3 clinical shifts. So whatever day your last day is, that next day is when your paperwork is due. And I only say that because some of you will have like 2 in the beginning and then 1 way at the end. And it's really difficult for me to get all of them read if I say the last day of clinical is this for everybody. So when you're done, get them turned in. It's your care plan, your time grid, your med list for each day of the rotation, and a journal entry for each day. So remember, you need all those 3 things and your journal entry. It doesn't have to be anything fancy. I just want to know what you did, who you cared for, how it went with the nurses, what your experience was, everything like that. And there's 3 of those. I generally get, you either love it or you hate it. And I mean, it's just, you know, people usually like the NICU because of that little tiny vulnerable population, and you really get to do a lot of hands-on stuff in there. But I hope everybody has had, so far, some have had good experiences, some haven't had nice nurses. It just depends. That's the other thing. If you get on to your clinical rotation and the nurses are not so nice, I would like you to please tell your clinical instructor right away. Please don't wait. If you're
Linda,
not nice- yeah,
just to be clear, so 3 clinical shifts, 1 care plan from each day.
yes,
Want 3 care plans and 1 journal entry.
for each day, right? So you go 3 days, so you're gonna have 3 journal entries and 3 care plans.
And 3.
Just put them together. So a care plan with a journal entry, a care plan journal, you know, like that, so that I can read them all together.
And those can be handwritten if we have nice handwriting.
Yeah, but the care plans have to be handwritten because I'm not going to make you try to do all that. But the journal entries, if I can't read them, I can't give you the points for them because some have been like really, really bad. So I just want to make sure that, you know, most of you guys have good writing, so I'm not going to worry about that. Hold on 1 second. You guys only have 1 peds quiz left, and I want to double check really quick here. We have musculoskeletal, and that's it. Okay, the last thing I wanted to tell you, two things. I keep lying. Your real life ATI for peds, there is this. I want you to upload what you do and your remediation. I'm going to use 1 student, and I hope she doesn't mind. I'm going to show you what it looks like. Hold on, I'm going to stop sharing for a second so I don't give anybody's information of what you've got. The real life maternal newborn ATI. And then okay. I'm gonna blot out this person's name. No, it's not working. Hold on. This gives you a good example of exactly what we need. It's not going to let me do it, but I want you to hold on 1 second. Nope, I can't do it. I'm sorry. It would just show that person's name and all that. I don't want to do that to them. So forget about that for a second. But the remediation is done very well. And it's a screenshot of each one that was done by this student. And it's a lot like what you're going to be doing for your actual ATI. So with that being said, you take a screenshot, put it on there, and that should be just fine for your real life ATI. And you get the 5 points for it. That's the 5 points that we came up with when I told you that our person didn't let us do that. okay, I have a quick question for you guys. We did cerebral and cognitive and neuromuscular already. We are doing our musculoskeletal, sorry. I'm supposed to have 2 refrigerators delivered after 1 o'clock today, and they showed up right in between what we were doing. That's why I had to go and do like a major move of stuff. It was a mess, but it all got done. Okay. Can you see our peds slides for musculoskeletal? Thanks. So we have this one, and I have to go look through, but I think we're almost done with this is our last lecture. I'm going to double check on everything, and then I will give you what the last quiz is on, but this should be very brief for musculoskeletal. Okay, what have we got? Yeah, just 1 chapter in the book and a couple in the ATI. Congenital hip dysplasia is something that you'll see quite often. You will see in the newborn nursery, and it kind of goes on later on when the infant, the newborn, gets a little bit older. So it's a variety of hip abnormalities, a shallow acetabulum, subluxation or dislocation, and it says often made in newborn period, often as hip joint laxity rather than dislocation. So I show you in the next picture real quick. I'm going to come back. Hold on. Here, this is the part that you see where the femur fits right here into the acetabulum, and the head of the femur is deformed, or the socket is shallow and it doesn't. So this would be normal. That would be, you know, showing you a hip dysplasia. Sometimes they're just popped out. They're dislocated and they need to get put back in, or actually maybe not get put back in, but we put on the newborns, if they have the x-ray and it shows that, we do a double diaper and kind of like hold it in place. It's kind of like a harness until they can get the proper, you know, treatment. When you check the infants on admission, you check their hips, you rotate to make sure that there isn't a dislocation. Oftentimes it can happen in childbirth. Or there is a malformation in utero. In childbirth, sometimes it can get popped out. That's what I'm trying to say. Often made in newborn period, often as a hip joint laxity rather than a dislocation. The ortolani click if it's less than 4 weeks old and older ultrasound. So treatment is the Pavlik harness, and it's abducted position for the newborn. So 6-month-old, monitor for any necrosis. They do an avascular necrosis. They do ultrasound and they do MRI on these babies. It's really something that's kind of it's pretty serious. So 6 to 18 months traction is followed by the spica cast if it's not been, if it's not been fixed. Older children, they operate an operative reduction. So they go in and they kind of do like a hip replacement almost, but that one is like the least used, or that's like a last resort, because then it's very many surgeries, because as a child grows, that joint isn't going to grow if it's a replaced hip. So it, depending on the child and the situation, the priority for us would be, skin care and facilitating the growth development, meaning that if there is a cast or a harness put on the child, you're going to be monitoring it all the way around. You're going to be monitoring over here where you see this little harness right here to the left, or these ankle that keep them abducted, keep the legs abducted and the hips in place, or then up a little bit higher here on the third one. And then this one goes, excuse me, around the chest and then down to the legs. I've never seen anything like that used. I have seen this used on peds, but the hip dysplasia is something that is very treatable. Bones and cartilage in the infants are flexible and pliable. And it says orthopedic pathology is more common in girls. in girls. In boys, the pathology does exist, but 7 times less often. The little girls I've seen with the harness, and it happens, I mean, they were in NICU for a little while for maybe another reason, but then we asked what was that? It was the harness. There's also Bryant's traction. This looks pretty outdated, but that's how it looks. It's a frame. They're a lot more high tech now, but it's a frame that stands up and it keeps both legs straight up so that the hip joints can get in place. Gradually they get, released and put down a little bit. The hip dysplasia for the Barlow's test, you go straight up and in, out and down. And this is the Pavlik harness, is the one that I have seen on peds before. This one where it was around their ankles and around the chest, and it kept the hip joints abducted. So ab means away. Caring for those kids is not easy. That's what I will say. These casts right now, I'll tell you, my friend's granddaughter had one, and they're so much different now. So the one off to the right is the kind that she had, this pink cast, but it's made out of, first it's the cast material, but then it's covered in a synthetic that is cleanable, wipeable. Because if you think of a 6-month-old to a year-old or 18-month-old having a terrible code brown blowout, it used to get on the cast, absorb into the clay part of the cast, and it was just a smelly, awful situation for the parent, for the kid. It caused a lot of skin irritation. So around it, they have like a special synthetic coating. And then the mother of the child that I knew that had one got duct tape and went in and did duct tape all the way around the area so that it could be wiped and cleaned easily, because it was really hard for her to be in the cast. And she was in this one, the long leg hip spica cast for a broken femur. But this one, the spica and this new pink cast over here is generally for the spica cast for that hip dysplasia. And hopefully the bone growth and the formation of the cast helps it grow into the right place. I mean, these kids do have to have a lot of physical therapy and occupational therapy to get the joints back into place. It says malformation of the hip due to imperfect development of the femoral head, acetabulum, or both. Most assessed at birth, but it can happen like 6 months or a year down the road, to where you can see that the legs are not symmetrical. There's a limp, that kind of thing. And the Ortolani sign is when the infant's spine and knees flex, and that's kind of abducted, and you can kind of see the little folds in the thigh. It's kind of, see here where it says click, even on this picture, you can see the little folds. There is some kind of imperfection or some kind of malformation. Asymmetric gluteal and thigh folds. So you can see in the back where there's just those little tucks, and you hold the infant up and one leg is just a little bit shorter. In taking care of them again, so there's a lot of cast care and skin care. The leg calf Perthes disease is an aseptic necrosis of the head of the femur. So you see it's got the blood supply, or the neck of the femur has been interrupted, or you can see how the normal head has developed. And then there's necrosis on the head. So the bone is necrotic. It's not developing because of the lack of the blood flow. Disturbance of the circulation of the femoral head causing ischemic aseptic necrosis. And that's something that surgical procedures are sometimes, done. It says an avascular necrosis for the femoral head and the growth plate. It can be damaged, and the shape is not normal to fit into the acetabulum. It happens more in males than females, ages 4 to 10 years old. Unilateral is more than bilateral. It happens usually, and they will have an intermittent limp, and that's how it gets caught. So that definitely there are hip replacements for that. Appearance is limp and pain are the signs. Diagnosis with an MRI. Treat with an abduction cast, non-weight bearing, and Conservative treatment may be necessary for 2 to 4 years. Surgery, in some cases, it's faster, but there's more complications and there's more surgeries that are going to have to take place because obviously that leg and that hip are going to grow and those aren't going to grow with it. So the main objective is maintaining function, but also you want to go a more conservative treatment, even though, you know, oftentimes these kids have to be in wheelchairs or walk with walkers, and, you know, hard on them to go to school like that. Talipis or clubfoot, we had one just the other day on mother infant, and it was not when City College was there, but the other school was there. And the child got, you know, assessed for that. And they did not see it on the high density ultrasound. They didn't see it. So it was kind of unfortunate because it was just in one foot, was the left foot. And the little girl was a beautiful little girl. And the mother was kind of tearful and kind of upset and needed a ton of reassuring. It says most common type is with the foot pointed downward and inward. That's how the baby was, often associated with other disorders, maybe due to a decreased movement in utero. It does require some surgical intervention. Serial casting begins shortly after birth and usually lasts 8 to 12 weeks. For those, how it says, treatment requires surgical intervention, but not always. That's one thing I know as a personal experience with a friend whose baby was like that. They did not require the surgical intervention. They just did the casting, and it was a series of casting and it lasted for 4 months. And this was after the child was already toddling. So they didn't really catch it quite at birth for that particular person, but as she started toddling, they noticed that the foot was turning in. And then I think at like 10 months of age or 11 months, when she was standing, they could see a very distinct turn in. So the priority for them was they casted the child, and after the cast was taken off, the child was corrected. So that was kind of nice. The priority nursing intervention and skincare is definitely skincare, and then the mobility factor. Like if it's a toddler, I mean, if it's an infant, 6 months, they're not going to be toddling. So you're going to be looking more at the skin. You're going to be looking more at the skin. You're going to be looking at the edges of the cast, making sure that there's CMS. You want to make sure that, you know, the toes are blanching. The areas around the top of the cast, you don't see any redness or any infection. And that's, you know, generally for any kind of cast, but this more so for these smaller little ones. This is a very distinct. I've only seen that once, and it was both feet, very, very distinct. And the parents had no idea. It was not caught on ultrasound. And here it says short tendons are lengthened and the long tendons are shortened. So that is a surgical procedure, very simple procedure. And then they are casted. So something to think about if you do get somebody on peds that is casted. For the spine, we talk about a scoliotic spine, abnormal curvature of the spine, lateral, congenital or develops later, more common during the growth spurts of early adolescence, and it's idiopathic. A diagnosis is made by physical exam or x-rays. Treating the curvature, there are several different ways. They treat it if it's less than 40 degrees is bracing. Surgical intervention is for severe curvatures. And then there's, you know, the lordosis, scoliosis. We'll go to a picture of that in a second. Internal fixation and instrumentation is, so there's a Harrington. A student did get to go in and watch that surgery and said, it was a male student, and he said it took him back to construction, because he came from construction and the back was opened and it looked almost like rebars when you're placing rebars in, like for doing cement work, sidewalks. And I was like, I've never heard that before, but that's an interesting, he said, except for it's just so much neurosurgery because of the spine. It's such a very interesting surgery to see. The postoperative care includes log rolling and many neuro assessments, pain management, skin care, and assessing for any kind of paralytic ileus, possible mesenteric syndrome from the arteries. So any kind of back and ileus for these patients could be very detrimental. They are usually, when they're having this kind of surgery, they are put on stool softeners before and laxatives so that we know that everything's flowing very easily and continued with that. So there's no straining. It says, don't forget the developmental needs of the adolescent. If it's somebody that's a little bit older that's having the surgery, that too can be a big part because, you know, all of their privacy and everything is taken away. You can see here the curvature of a scoliotic spine. I always remember it like with an S, a mild S, and then the normal spine, of course, is straight up. I have one normal spine, scoliosis of the spine, where one shoulder is they're uneven, the prominent uneven shoulder blade. The hip appears a little bit lower on that side, asymmetric flanks, and it's not hard for a healthcare provider to spot that. This is the picture where a healthy spine, of course, straight up and down. The thoracic spine, you can see just a slight tippage in the shoulder. Then the lumbar scoliosis, you can see where it's down lower, but you can still see the other shoulder is up a little bit higher. Lumbar thoracic scoliosis has both areas affected. And again, a drooping on one side is very slight, but you can see it to the left side. And then when you have combined scoliosis where both areas are compensating, you don't have any kind of change in the shoulders, but definitely as they walk, you can see there's a limp, and you can see here in the center where this part of the hip might be like off just a tiny bit. Shoulders do look the same. This is just such a great picture to give you an idea in your head of what you're dealing with. So normal is pretty straight. Lordosis goes in a curvature in this area. Kyphosis up higher, and then the scoliotic spine, of course, is like that slight S movement, and you do definitely see a shoulder being raised. Spinal disease, you have normal, lordosis, kyphosis, flat back, sway back, and scoliosis. And you see more of the kyphosis and the sway back in the older patient. But as a child, if there is any kind of interruption or any type of scoliotic condition, you can definitely see them in the shoulders, and it's something that would definitely be addressed. Like again, like with casting or with surgery. Lastly is our juvenile idiopathic rheumatoid arthritis. It's an inflammatory disease with an unknown cause. It occurs in children less than 16 years of age and lasts 6 weeks. Clinical manifestations, they can mimic other things. You'll see stiffness, that's what meningitis. You could think that's swelling, loss of motion in the joints and tender to touch. So a lot of the NSAIDs and the slow acting or anti-rheumatic drugs are used. Corticosteroids are used. They do a lot of physical therapy for the therapeutic management, occupational therapy. Swimming is one that I've heard that they do a lot for smaller kids at the rehab center in the warm pool, and then moist heat for pain and stiffness. And again, general comfort measures. That's mostly for what that is. But the idiopathic rheumatoid arthritis is also a very difficult diagnosis to take because parents don't know where it's coming from, why it's happening. And you see like a little child all of a sudden have a swollen knee or a swollen elbow, a difficulty walking. And you see here, the arthritis is causing a thinning in the cartilage, difficulty, ambulation is difficulty, crawling even. And it can be a gradual onset where they're diagnosed, so they have to have blood drawn, and they have different types of treatment for each one. But here for complications, it says musculoskeletal, which we're talking about right now, deformities and demineralizations and stress fractures. Hematologic wise, they could become, anemic or splenomegaly, a large spleen. Cardiac, it could be pericarditis, myocarditis, or valve involvement, which means there would be a conduction defect and they would have to be, put on medications for, maybe like a, help me out here. What is the med that we give? A digitalis, pulmonary fibrosis, pneumonitis, pleural disease. So there's a different things and different ways that this kind of rheumatoid, these idiopathic arthritises can cause problems for kids. Some are very mild. They can get treated with the NSAIDs and corticosteroids, and they can correct themselves. Some go on for longer, but it is something that I have. Let's see if I have that here. Different criteria and treatment. I'm looking for something else. Hold on. No. That was more in the book that I was looking at when I was reading it. So the rheumatoid arthritis, the risk factors, increased incidence in women, but any age, and can peak. So it can come back to them arthritic wise. But for children, the main focus that I have for you guys right now is understanding the different types. So down here, I have kind of a list of the different types and what they're about. But I do know that when I tell you in a couple of seconds what's going to be on the quiz, this is definitely going to be on the quiz. And that is your free response question. So just the different types and how the treatments are. So it says classification of juvenile idiopathic arthritis. It's on that page in your book. It talks about the systemic, the oligoarthritis, polyarthritis, rheumatoid factor, psoriatic arthritis, enthesitis related arthritis, and then the undifferentiated. So in talking about this section, that's what I want you to focus on. Be able to explain each one to me, not in great depth, because you see it is on your Canvas quiz and you have just a section. You could write a whole, some people write so much stuff. I'm very impressed with that, but I just want you to be able to explain what each type is, and it's all on that page in a perfect little box. And I think it's important to know, because if you're treating those patients, you want to know exactly what you're dealing with. We have one last quiz. I'm going to look because I'm pretty sure we covered everything, because all those modules got mixed up in the end, but I'll go over that today. Look at all of them. I know I can tell you right now for the last quiz, there'll be maybe 3 or 4 on meningitis. There'll be a couple of Rice syndrome questions, hydrocephalus, like 2 or 3 on those. Seizure disorder, a couple of those. Just one on the diabetic area that we talked about, just plans of care like that. Koenig's and Chauvet signs, the Koenig signs, talks a little bit about those. And then randomly there's scabies and a couple of lice questions thrown in on this quiz. The main free response question is just this: classifications of juvenile idiopathic arthritis. So be able to give a little insight on each one of these types, and you will be solid for this section. I will look and let you know next Monday when we're in our med surg, because we still have a med surg. I think just one more lecture on med surg, maybe 2. I'll let you know if we're completed with everything, but this so far is up to the last quiz. And then I will put a study guide up in pediatrics for your final. ATI is something that you all need. You think, oh, we're done. The last few weeks is the main focus is that. So definitely important to go over it and look at everything, do every practice exam to get prepared, because they're not easy. And I'll tell you, they pile up and you have one day to retake them. They're all on the same day. I'm going to look right now. You guys can still see this. So there was our break. Next week is just immunity. And I think that is our last one. I don't believe we have anything left on peds. If we do, I'll talk about it then. And then the following week, you have your primary ATI and your peds ATI. Then the next 2 days or 3 days after, you have your maternal newborn ATI. So it all piles up at the end. That's why these few weeks that you have, like you have this week, not much to do. Next week, not much to do to study for. It's all your focus needs to be on your farm and your peds ATI. Getting your pre-tests done, getting them uploaded, do with that remediation. That directions are super explicit that Mary went over and that she put on we put in the syllabus again, so it's there, but super important, because if you guys just do a 2 with the remediation, you're done. You don't have to revisit it, and you don't have to come back, because then it's the final quiz, and then you have to do the farm ATI and peds ATI, when you could be just studying and wrapping things up and getting ready for your final. So please do whatever you can to study for your ATI and get a 2. There's usually, I'll give you my usual, the usual number average is I get 3 to 4 3s from students that say they don't know how they did it. Then I get a majority of 2s, and then 5 to 6 1s, maybe 1 below a 1. But as far as everybody's concerned, you've been practicing every week. It isn't just for a point. It's so that you can understand the verbiage, so that you can understand the way they speak and the way the questions are set up. So please study. Like if we're done now, we are done, and it's only 11:45. Please study your ATI and get those quizzes done. The 6 students that are staying in after everybody signs out, please stay in with me so